Drakkar. One more round of applause for him. Thank you. Say that he was sponsored by McKay Surgical Center. And sometimes in my office, I think to myself, what we have here is a failure to communicate. I miss Paul Newman. But, and when I went to Kirtly's lecture on how to communicate with our patients, I just thought this is something that should be shared. She's got great ideas on ways to get through.
Well, it's always hard to follow a great speaker, especially someone who's spoken for an hour and a half and your bottom sides are getting tired, and especially if I'm going to talk about numbers. So feel free to stand up, walk around while we're listening to numbers, because I really want to talk to you briefly about numeracy, what patients hear when you give them numbers, and how unfortunately we don't even understand the numbers ourselves. So it's trying to come up with numbers that you and your patients can use. So I'm going to talk about some different numerical means of presenting risk. I'm going to give you 3 graphical methods that have been evidence-based ways of presenting risk to patients, and factors that affect patients' response to risk. So in my disclosures, go ahead.
I'm very sorry. So there's a resident poster exhibition next door, and these guys have gone to some work, and it'd be nice if people are interested in that don't like Kirtly would go look at that during that time.
Isn't it broadcast over there so you can hear it anyway while you're over there? No?
Oh, okay.
I thought I heard it in that room.
Yes, you could walk over there and listen to her.
Right.
And look at the
So if you
posters.
don't want to talk
I'm
about
very
numbers,
sorry.
feel free to go look at posters. And then you can come back and we can critique the numbers in their posters, right? So this is in disclosure. A lot of this material was actually developed by the Association of Reproductive Health Professionals. So I want you to know that. And the other as I like arithmetic. And you need to know that I like arithmetic, so I'm comfortable with numbers and I like working with numbers. The other thing that you need to know is I'm an OBGYN who's a reproductive endocrinologist. So a lot of the examples that I'm going to be using are kind of, gynecology numbers and OB numbers. So I think 2 plus 3. Do you think all of you could do that? At least 99% of you could get 2 plus 3 equals a number. You think we get it right? Well, if you were asked then that there was a 50% decrease in the number of people who answered the question incorrectly, what would the subsequent percent of people who answered the question correctly? Now this sounds like the SATs, or it sounds like what you did in college. But this is the kind of thing that you get in your literature. They will say there was a 50% reduction of patients who didn't take this medication and subsequently had this outcome. And unless you're comfortable in manipulating the numbers, you don't really know how to figure out what numbers we're really talking about. So probability statistics. So there's a 50% chance of rain today and a 50% chance of rain tomorrow. What's the chance that it will rain today and tomorrow? Anybody know what that is? 75%? Okay. Pardon? 25? No, it's going to rain. Oh, right. Sorry. You're right. See? 25%. What's the chance that it will rain today and tomorrow? And what's the chance it will rain today or tomorrow? Anybody can figure that one out? It's about 75%, but that means that the rain is independent. So in fact, if we have a big storm system coming through, it's very likely that the two variables depend on each other. So once again, when we start talking about things with real patients, they may fall into a case where they're more likely to have 2 bad things happen because they have an underlying condition. So it's difficult for us to really think about individual patients when it comes to risk. And then how do we transmit risk? The 5-year survival of stage 4 ovarian cancer is about 12%. Aggressive chemotherapy can increase the 5-year survival by 50%. So what's the chance of surviving stage 4 cancer for 5 years if they undergo aggressive surgery and chemotherapy? And what do you think the patient hears? So if a 50% improvement A 50% of 12%, add it together and you get 18%. Are you with me now on these high price numbers? But when you say there's a 50% increase in their chance of survival, what do they hear? There's a 50% chance of their surviving. So these numbers, using numbers, we need to use absolute numbers and not percents because the patients can't figure it out. So how do we express risk? I think we express risk in a couple different ways. We want to know, patients want to know when there's a risk exposure, what is the cause of that risk? Meaning, in my business, I'm just dealing with a cousin who's going to have a mesh procedure for a vaginal vault suspension. And for those of you who aren't gynecologists, putting mesh in the vagina is asking for trouble because mesh erodes into bladders and rectums and it causes pain in about 10% of people. So, however, mesh works better than just putting stitches in. So it works better. So how do you decide which one patients are going to tolerate and how much of the risk is actually attributable to the mesh? Let's pick an example, sort of, that some of you may know. You know that moderate drinkers live longer than non-drinkers. You guys have all heard that? People who drink moderately live longer than people who don't drink at all. So is the alcohol actually contributing to longevity, or is it that people who drink actually moderately do it with people, they have friends, they laugh, they're social, and actually being social and having friends and laughing all independently are associated with living longer. So we don't know whether it's the alcohol or it's other behaviors that are associated with living longer. Women who take vitamins actually don't live as long. So taking vitamins is associated with a lower long-term chance of living. And this is in the Iowa Women's Study. Well, it could be that it's not that the vitamins are killing them, but when women don't feel very well, they don't feel very healthy, they feel kind of tired, they may take vitamins. So it's not the vitamins per se, but it's actually the people who take vitamins. Now, when you read about things in USA Today, or even in your own literature, causality doesn't always show up. So an association is not always a cause. And associations all the time out there, there's a 2 times increased risk, or there's a 30% increased risk of dying if you play hopscotch when you're 3. Well, it could be because you're playing hopscotch in the street and it's not hopscotch per se. Our last speaker very carefully mentioned that if you start getting relative risks of 4 and 5 and 6, then you begin to think of a causality. The associated risk of smokers and lung cancer is about an 8-time increased risk over people who don't smoke. Once you get relative risks in the 8 times, then you are more likely to have causality. When you have a 30% increased risk, which you read all the time in the newspaper, it could easily have nothing to do with the activity involved. So I'm very careful about using things that show increased risks of small numbers. So I actually don't like relative risk ever when I'm talking with patients. But people use it a lot. People use relative risk and they use numbers like there's a high risk or there's an extremely high risk. High risk, a low risk, extremely high risk are all value judgments. Now, if you have a document in your office that says, this is what we mean when we say low risk. It happens less than 1 in 1,000. Or low risk is less than 1 in 100, and very low risk is less than 1 in 1,000. High risk is 1 in 10, very high risk is maybe 1 in 3. You don't have that document. So when you say there's a very high risk, the patients have no clue what actual numbers that they need to make a decision about. They know that you're worried, so you say there's a very high risk. But very high is a quality assessment and a value judgment. So I don't use very high risk or very low risk. And I don't like relative risk for reasons I'm going to explain. So I actually like absolute risk. Out of 1,000 people, this many people, if you take this drug, will have this side effect compared to this many people who don't take the drug. So I like absolute risk or attributable risk. And these are numbers that people can understand. They don't understand relative risk at all. And in fact, most of my medical students don't. Because when you give relative risk without using a denominator, meaning how many people are you really talking about? Let's take the case of birth control pills and clot. Oh, let's take the case of birth control pills and a pulmonary embolism. There's a 2 to 7 times increased risk of a pulmonary embolism if you take birth control pills compared to if you don't. What is the real risk? It's about 1 in 100,000 to 4 in 100,000. So the attributable risk of a PE on birth control pills is about 3 in 100,000. So the relative risk looks big, but when you look at the denominator, it's trivial. It's no longer clinically applicable. So I don't use relative risk when I talk to patients. I use absolute risk. So here's an example of thromboembolic events. How many women out of 100,000, 30 will develop? The other thing is that people don't like 100,000. So when you express risk, you say per 100,000, 100,000 is a number that's so big, people really don't process it very well. And 30 in 100,000 is like, for me, 3 in 10,000. So I always divide it, and so they have a whole number like 3 in a smaller number like 10,000. So I try to give them numbers in something that they might understand. And Rice-Eccles Stadium is an example of when you fill it all up, at least in Salt Lake, maybe it's Weber Stadium. When you fill it all up, this is 10,000 people, and the difference is 3 of those. So attributable risk is, as I mentioned, so if the absolute risk was 4 in 100,000 for PE, and it's 1 in 100,000 for women don't take birth control pills, the attributable risk, meaning the risk associated with people who took the medicine, would be 3 in 100,000. So relative risk is not useful in communicating with patients. They don't understand it. And often, you don't even know what the denominator is unless you go to the literature to try to figure it out. So we've kind of talked about a risk, and that way to put it. So you can use relative risk of cancer in smokers versus the risk of cancer in non-smokers. So the attributable risk of lung cancer, or cancers in general, in smokers, there are 90 more cancers per 100,000 people, or 9 in 10,000. Now, in fact, we all know smoking is going to kill you. But in fact, it usually doesn't, at least not cancer. It's not good for you, but the attributable risk is relatively small. So relative risk is the frequency of the exposed divided by the frequency unexposed, but without using a denominator. How many people did they really talk about? It's not a useful number. It's meaningless. And of course, I use the birth control pills number, 2 times increased risk of clot, or the 2 times increased risk of a PE, because women use birth control pills all the time, and they can be scared out of their birth control pills when they hear there's a 2 times or 3 times increased risk. But when they hear it's per 100,000, if it goes from 1 to 3 per 100,000, it no longer becomes clinically relevant to them. So interpreting relative risk is something that you need to understand. Relative risk greater than 1, like 1.3, means that there's 30% more. Let's take a look at the Women's Health Initiative and using hormone replacement therapy. So we know that there's a 30% increased risk in breast cancers in women who use hormone replacement therapy with estrogen compared to those who don't. What did that actually account for per year in real numbers? It was 1 extra breast cancer detected per 1,000 women per year. So that 30% increase scared a lot of women and doctors out of prescribing hormone replacement therapy for very symptomatic women. But the real number from the Women's Health Initiative was 1 extra breast cancer per 1,000 women per year, attributed to the estrogen. Women need to make decisions based on numbers that they can use. This is more on relative risk examples. We talked about blood clots, comparing 2 different kinds of birth control pills. The relative risk is a little higher with one kind of birth control pill versus another, but we're still talking about 15 per 100,000 women in differences. I'm not going to give you any more OB risks. The other point that's really important is that the patient actually falls into the category that you're thinking of. So when you're looking at examples of literature where they take maybe 100,000 people, that would be an epidemiologic study, or 1,000 people might be in a randomized trial, they decide what people are going to be in their study. And it could be that your patient isn't even qualify. So your patient must maybe much riskier or much less risky. So we know that if you flip a penny, and that there's flip a penny, you have a 1 out of 2 chance of getting heads if you're looking for heads. Now, if you have a 2-headed penny, then of course it's a 100% chance. So if you have patients who are particularly different than the study population that you're looking at, their risk may be very different. So the big randomized trial homogenizes people into one group, and they exclude a lot of people who they feel might be at higher or lower risk, but your patient may fall into that. So you can't always use the risks that come from a randomized trial. If you've got a patient with 3 comorbidities, she's obese, she's diabetic, she's hypertensive, and she's got an abusive husband, and it could be that those things together put her much greater risk for a fall from alcoholism, let's just say. So how do you communicate risk? Well, you can use relative risk or attributable risk, or you can use absolute risk, and I either like absolute risk, meaning the real numbers, or I use attributable risk, which how many of the people who got this drug had this specific outcome. So you can say 3 out of 10 women for whatever develop nausea, or you can say a 30% chance of having nausea. About a third of your patients don't understand percents. So a lot of people don't get percentiles. If you say 3 out of 10, most people can imagine 3 out of 10, but a lot of people aren't any good at percents. A lot of smart people aren't very good. Headache happens in 1 out of every 333 women, or headache happens in 3 out of 1,000. People like round numbers. They don't like fractions, and they don't like 1.2s, they don't like decimals. They like whole numbers, and they like the denominator to be a round number. So you could say 1 out of 333 women develop headache, or you could make, say, 3 out of 1,000, and in trials looking at how people process information, they understand 3 out of 1,000 better. There is actually a journal of medical information where they do trials to try to assess how people from different cultures and different reading backgrounds actually figure stuff out. So you could say that oral contraceptive use, using that example, increases the risk of heart attack 2.5-fold. That sounds kind of scary, of course, but heart attacks occur in 4.2 out of every 1 million OC users and 1.7. Now, I told you people don't like fractions, so I'd round the 4 down and the 1 up. So the attributable risk of heart attacks in OC users is 2 per million. Now, million's a big number, and 2 is a little number, but people don't like fractions, and they don't like decimal points. So you can give them the attributable risk, which is a number that they could use, and they're making a decision. Now, here's where we might differ as to what is high risk is less than 1 in 100, moderate risk is 1 to 10 in 1,000, low risk is 1 to 10 to 10,000, very low in 100,000, minimal risk. I don't know, for those of you who are surgeons, when you say there's a low risk of a hemorrhage or a low risk of an infection, that's usually low is like 1 in 100, 1 in 100. Well, they would say 1 in 100 would be a moderate risk. So what you call low risk and what people who study this stuff call low risk is different. So I think when you're saying there's a low risk or minimal risk, you should give them some real numbers rather than what you perceive as low. Now, you can't put risks in terms of other things. So here's the risk of, and once again, because I'm an OBGYN, I use birth control pills. 1 out of 3 women in the country have used birth control pills. So skydiving, this is the risk of death per 100,000. There's skydiving, driving, pregnancy, riding a bicycle, using birth control, and you can see that the risk of birth control is significantly less than the risk of dying from driving. So sometimes you can compare risks, and you can use these risks. You know the risk of what you're doing, the risk of a hip replacement or risk of using an ACE inhibitor or whatever, and you can add these risks together because people sometimes have an idea about risks of other things that can be helpful. You can compare it to other medical conditions. So here's the risk of birth control pills. Here's the risk of a venous thromboembolic event in the general population. Here's birth control pills, low dose. And here's pregnancy. So if you're trying to avoid pregnancy and you're worried about blood clot, well, first of all, you can use something other than birth control pills, but it's much, much higher risk of blood clot if you're pregnant than if you're using birth control pills. But I use that word higher, and when I was talking to the patient, I actually draw bar graphs on the sheets on the table in my exam room, and I label them specifically for them. I draw a bar graph, I put their specific situation, and I give them a bar graph. Well, why do I give them bar graphs? Because people understand bar graphs better than tables. They understand bar graphs better than line graphs. They don't understand pie graphs all that well. So bar graphs of all the different ways of presenting data is probably the best. I'm going to give you an example of the paling palette here just a little bit, because the paling palette also has stood up the test of time. So here are our categories. This is a way of presenting data. So that, once again, this is contraception, but it could be anything. This is more effective, and this is effective, and this is less effective. So you can show people things like this, where they have to read the words, and you can color code it. You can then add the color coding and and a number to it, like this. Or you can show them a bar graph, and this is the show them a bar graph, and it turns out that if you show people categories, they don't get it very well. And this is comparing hormone shots to the pill, or pill versus condoms. But in general, if you show people just the categories, this was the categories, this is the categories and numbers. But if you actually show them the categories and numbers, they don't understand it very well. If you give them just the numbers in a bar graph, they're most likely to understand what's going on. But understand, look at this is still only 37 and 27%. So people walk out of your office and you think you've done a great job at explaining things verbally. But it turns out people don't get it that well, which is why I used to just draw it for them on a piece of paper, tear it off the table. They have not been on the table yet, so I'm not using the table that they just had their pelvic exam on. You're not using that paper. I give them fresh paper. And I roll it off and I say, here, this is you. And they watch me do it and they hear me say it. So a paling palette is the way of, if you're looking at 1,000 women or 100,000 women, you can actually take, and you can go online and make your own paling palettes. You can just Google palingpalette.com or risk.com, and they will give you examples that you can print out, and you can color them. So here's 1,000 women. So you can make 1,000 little ladies here, or 100. So here's an example of 100 ladies, and we're going to look at the risk of breast cancer in women in general, and then women who take birth control pills. So here is the risk, these little pink ladies here. Here's the risk of breast cancer in a year of 1,000 women, just American women. And if you add hormone replacement therapy, you get an extra kind of 0.8 of a woman. So for women who are afraid of taking hormone replacement therapy, they're very symptomatic, they're having a lot of hot flushes, they're miserable, or they can't have sex because it hurts too much, you can show them, okay, here's what it looks like for women if you don't take hormones, and here's what it looks like if you do take hormones. And most people can use a paling palette. So I use a paling palette, and I can print out paling palettes by the 100 or the 1,000 and just color in the numbers if that's what I need to do. I did IVF for about 35 years, and teaching people about the relative chances of getting pregnant with IVF and having them understand it when they're desperate to get pregnant. You need to give them some stats in bar graphs in ways that they can really understand, even though our patients are really smart. So here are, once again, people understand bar graphs pretty well. Here's the risk, come together of serious events if you're an OC and a smoker. And here's what happens if you just use, I don't think my little pointer's going to work. But you can use bar graphs, and bar graphs work pretty well in terms of explaining things. You don't need to know the numbers here because you're not using birth control pills right now. But so they actually did a study in the Journal of Medical Decision Making, and they took people who were of low literacy and high literacy. So these open bars are people with low literacy, and these are people with high literacy. And here is how much they actually could give you back the numbers or the gist of the stuff. And about 100% of people got the bar graph. Only about 50% got the line graph. And the pictograph was up, that was the paling palette, and that's almost 100%, and the pie chart. So this is the kind of data, and people of high literacy, like medical students, they usually can process all these things. But you can see that once you use a line graph or a pie graph, you drop the perception of understanding by almost 50%. So it's a big drop. So I think you need to understand how well people understand numbers, which is not very well. You need to put the risks in context of something they do understand, like driving or skydiving or something like that. Remember that there are cultural literacy and developmental issues, so the person you're talking to might be another physician, in which case, even if you give relative risk, the smart person would say, what's the denominator? So if my doctor gives me a relative risk of 2, I would ask him, what's the denominator? It's 2 times what? How risky is that? And remember that discussing risk may help people understand it, and then you can put, when you dictate, you can, or when you fill out your EMR, you can say how you explained risk. I think when providing information about, I talk about risk reduction, how to reduce risk, and then I always present absolute risk. And I try not to frame things with values like really high or really low, because that's a value judgment. I try to give the real number, and I use risk comparisons. So it's not infrequent for someone who had an operation and then ended up with a big infection in their abdomen or whatever to say, he said that that was a low risk, and I thought low was 1 in 10,000, whereas the surgeon thought low was 1 in 100. Of course, when it happened to you, then it was 100%. But I think you need to know yourself and how you're framing the issues. So you want to frame things to make the patients do what you want them to do. I get that. And you want to make yourself look good. But I think you also need to know your patient and how much numbers they can use. So I think you need to clarify the situation, provide the information in numbers that they can use. What are the risks of the patient? So I'm thinking about, some patients will say, well, the risks of these 2 things are about the same. So the risk of, let's go back to mesh in the vagina. So the risk of having the mesh not, having the operation not work, if you just put stitches and you need another operation, is about as high as putting mesh in and having mesh erosion, which causes chronic pain and dyspareunia. So the numbers are the same in terms of percents, but some people will say, I'd rather assume this risk than that risk. So some people, when the numbers are the same, patients can get to decide, but they have their own values on how they're going to put that together. And I think that I usually, if I give people handouts, I know they won't read it. If they watch me draw it or write it on a piece of paper, which happens to be in the exam room, I've got all this paper, I think they remember a little bit better. Risk perception is affected by a number of people, and it's often what their girlfriend died of. So women will come and say, I want my colonoscopy because my girlfriend died of colon cancer. So, well, you know, living next door to someone with colon cancer doesn't increase your risk, but their perception is high. So some people are much more afraid of a particular outcome because of someone that they know. So I think you need to ask what the patients are most concerned about. What is your number 1 concern with this medication or with this treatment or with this surgery? What other things are relevant? What makes them different than the average patient? Are they heavier? Are they already taking narcotics, which means they're much more likely to have pain issues after their surgery? What tools do you have? In your handouts, do you have bar graphs? Or is it a handout with a lot of words that you know is just going to be tossed when they come out? And then how do you give guidance? So I'm not going to talk anymore about that because we're running a little short of time. I think risk is also a value decision. So I'm going to give you some real numbers about mammography. For every 2,000 women ages 50 to 70 who are screened for 10 years, so that's 200,000 mammograms, 1 woman will be saved from dying from breast cancer. That's how effective mammograms are as a screening tool for breast cancer. 10 will have their lives disrupted by unnecessary overtreatment, meaning they have a mammogram, they have to come back for another screening, or maybe it looks a little abnormal and then they get a biopsy. I think we all believe that mammography saves lives, and it does, but I don't think that we actually know that it saves lives. You have to screen 2,000 women age 50 to 70 for 10 years to save one life. I don't think we know that. And the reason that women continue to have mammography is that they all know someone who had breast cancer, often didn't die because breast cancer is very curable, and they don't want to get it, and they think that mammography is a pretty benign thing. This comes up when we think about whether we're going to screen every other year or start screening at 50. And with a screening tool that's as poor as mammography is in reliably detecting and saving lives from breast cancer in populations, then the difference between screening every other year and every year is not that big, and we save a lot of money every other year. But if a person had a girlfriend who died of breast cancer, she's believed always that a mammogram every year will save her life, then she probably ought to have a mammogram every year, even though the data doesn't support it. So another way of putting it, screening mammography starting at age 50 saves a 1.8 lives over 15 years for every 1,000 women. This is another study, but the numbers are about the same. You have to screen 1,000 to 2,000 women for 10 to 15 years every year to save one life. So media influence, often if there's something big in the media, someone comes in and they say there's a 30% increased risk of dying from breast cancer if I eat oranges, they think that's a huge risk. But in fact, a 30% increased risk calculates to about 1 extra case per 1,000. And I made up the oranges. I don't think that oranges are associated with breast cancer, but they don't know. A 30% increase looks really big to them. So who's the individual that you're talking to? How well do they understand risk? Are you looking at your computer? Are you really looking at them? How do you individualize their risk? How do you present it? Bar graphs, whole numbers, not fractions. And how do you characterize the risk? Be careful about your words being high, low, or very high, because they don't agree with your numbers. People worry about risks that they can't control. So those tend to be worries that they think are bigger. Like we worry about dying in an airplane crash because we don't think we can control it. We don't worry so much about a car crash, which we can control, even though airline crashes are much less likely to kill you. Are involuntary, meaning you didn't ask for it. Are associated with a particular dread, meaning, and are novel or unfamiliar. Result from man-made sources rather than quote-unquote acts of God. So are more easily recalled. So some risk people give more weight to, even if they're very uncommon. So I think you need to understand how to communicate it. You need to establish a trusting environment. You need to have some good tools with graphics that are specific for this person. Don't use relative risk. Use whole numbers. Use bar graphs if you can. If you've got another physician, then maybe you can use anything you want, but most people aren't very numerate. And I'll just quit here, and thank you very much for staying and sitting for another half an hour. Thanks a lot. I know that we're over, so I'm willing to take any questions while we're getting lunch. So thanks.